Hello and welcome everyone. My name is Renee Garrett and I'm your speech therapy PD podcast host for Brainstorms, Functional Neuro Rehab for SLPs. Before we get started, we have a few items to alert you to. Each episode is 60 minutes and will be offered for zero point 0.1 ASHA CEU. Here are the financial and non-financial disclosures for our guest. Dr. Cara Donohue is a salaried employee at Vanderbilt University Medical Center. She received grant funding from the NHLBI, AHA, NTF, and the Vanderbilt Institute for Clinical and Translational Research funding. She receives a small honorarium from Speech Therapy PD for her participation in this podcast. She has no relevant non-financial disclosures. Dr. Wes Ely reports grants from the National Institute of Health and the Veterans Administration. He worked with Eli Lilly as an unfunded investigator on COVID-19 trials. As an NIH investigator designing and conducting long COVID trials, the study team received study drug from Eli Lilly without any personal compensation. He owns no stocks or paid consultancy arrangements with pharmaceutical companies and has no relevant non-financial relationships. My disclosures are that I am the owner and founder of BrainBridge Connect, and as the host of Brainstorms, Functional Neuro Rehab for SLPs, and other educational webinars on speech therapy PD, I do receive financial compensation. I'm also an adjunct instructor for both James Madison University and Old Dominion University. My non-financial disclosure is that I'm the secretary for the Communication Disorders Foundation of Virginia. Now, without further ado, we welcome our guest, Dr. Cara Donohue and Dr. Wes Ely. Dr. Cara Donohue, PhD, CCC-SLP, is a practicing speech-language pathologist, assistant professor, medical speech-language pathology director, and innovative research in aerodigestive disorders, or IRAD, laboratory at Vanderbilt University Medical Center. She completed her doctoral studies in the computational deglutition lab at the University of Pittsburgh and her postdoctoral research fellowship in the Aerodigestive Research Core Laboratory at the University of Florida. Her research work aims to improve clinical care, patient outcomes, and quality of life for individuals suffering from swallowing disorders. Her current research is funded by the American Heart Association, the Alzheimer's Association, and the NHLBI. Dr. Wes Ely, MD, MPH, is an internist, pulmonologist, and critical care physician. Dr. Ely earned his MD at Tulane University School of Medicine in conjunction with a master's in public health. He serves as the Grant W. Little Endowed Chair in Medicine and is a physician scientist and tenured professor at Vanderbilt University Medical Center. He is also the Associate Director of Aging Research for the Tennessee Valley Veterans Affairs Geriatric Research Education Clinical Center in Nashville, Tennessee. He's the founder and co-director of the Critical Illness, Brain Dysfunction and Survivorship, or CIBS Center, and a pioneer in the investigation of delirium and long-term cognitive outcomes, including dementia, in survivors of critical illness, with continuous NIH and VA funding for 25 years and over 600 peer-reviewed publications. He designed and was a lead investigator for the study of JAK/STAT inhibitors in acute COVID-19, which successfully proved a survival advantage for this class of medications, leading to FDA approval and the strong WHO recommendation for these medications for hospitalized patients receiving oxygen. He is the principal investigator for an NIH-funded phase 3 investigation of immunomodulation for patients suffering from long COVID. His CIBS Research Center hosts free daily support groups to provide community and help in recovery for patients with long COVID and their families. Dr. Ely is the author of a work of narrative nonfiction entitled Every Deep Drawn Breath, from which he's donating 100% net proceeds to help COVID survivors and family members rebuild their lives. That was a big mouthful. Thank you both for bearing with me and for being here to record this highly, highly important to me topic. So let's kind of jump right in, and whoever wants to take on the importance and kind of talk about the prevalence of dysphagia with the CIBS population in the ICU.
Sure, I can jump in, and thanks for having us here. So To be determined. We haven't actually done any prospective studies yet through the CIBS Center, so we're hoping to do that soon, looking at things like prevalence of dysphagia and ways that we can maybe screen for it better and also help people recover better. But just in general, in patients who are critically ill, we have looked at that, and we actually recently did a systematic review where we examined prevalence of dysphagia in critically ill adults, and we found that the prevalence ranged pretty wide. And a lot of that is just due to the types of assessment tools that people use to assess swallow function. So some of the studies used a clinical bedside swallow evaluation or more screenings, which can sometimes miss people who are silently aspirating or might have other swallowing impairments that we can't detect without imaging. And there's also a variety of different definitions that people use of dysphagia. So I think the range we found was somewhere between 15 to 100% of people during the acute stage that had dysphagia. So that's a pretty broad range. So upwards of almost every critically ill adult that was assessed ended up having some sort of dysphagia. But like I said, I think there's a lot of work to be done with really understanding how we're even defining dysphagia and really zeroing in on what the true prevalence is in this patient population so that we can better identify the folks who do need further assessment.
Yeah,
That was
and
a
I think
great way to introduce this topic, Cara. And thank you, Renee, for having us on. As a physician in the ICU, who you can see has a lot of gray hair and has been up here a long time taking care of critically ill patients, 30 years or more, I can tell you that it's basically a public health catastrophe, the amount of aspiration and upper airway dysfunction that we have in our critically ill patients. And the reason I say it's a public health catastrophe is because it's extremely prevalent, as Dr. Donohue just said, and we don't do anything to prevent it, and we assess it only after we basically know that there's a problem and patients are getting aspiration pneumonia. We're getting better about having our SLPs come up, speech language pathologists come up and assess patients because we think there might be a problem, but I shudder to think the number of people that did have an aspiration problem and upper airway dysphagia problem that I didn't adequately assess prior. And when we do assess and they have tremendous problems, what does that mean for our patients? Because it basically relegates them to a very protracted period of time with NG tubes, PEG tubes, et cetera. And a lot of that, I believe, could have been prevented if we had gotten them early up, mobilized, practiced the ABCDEF bundle, had much less sedation, and had gotten them back to the land of the living faster. A lot of this, I believe, is iatrogenic.
Yeah, and I was sharing with Dr. Donahue earlier that, I worked in ICU for several years. And so it's one of the things that I found to be part of an issue was that a lot of the internal med docs that were co-treating with the pulmonologist or the intensivist in the ICU were often not as supportive as the intensivists were, which is interesting because we all were, need to be on the same page. The whole goal is to prevent this preventable condition as much as we can. And I think that doing things like systematic reviews is certainly helpful because now we've got this data where it's more data driven and we know what we can use these things for to develop better protocols to get better earlier intervention from SLPs. So one of the things I did want to have you describe is that A to F protocol for ICU care, because I think that's something that a lot of people are unfamiliar with, at least where I worked. I know they were unfamiliar with it, and I think it's fascinating.
Sure. Let me just, for the listeners here, thank you so much for being on with us today. Cara and Renee and I are so glad that you're here. The ABCDEF bundle is basically, we short phrase it to the A2F bundle, and it's 6 steps that make so much sense from a humanistic perspective for our patients who are suffering and critically ill. And the A stands for analgesia. The B stands for both spontaneous awakening and spontaneous breathing trials. So that's stopping sedation, stopping the ventilator. The C stands for choice of drugs, where we try and avoid drugs that will cause neuromuscular and psychoactive medications. The D is delirium, and we have easy ways for nurses, doctors, PharmDs, respiratory therapists, anybody to measure delirium in the ICU, because when somebody's brain isn't working from a central perspective, They also have oftentimes peripheral problems, especially in cranial nerves, and then therefore upper airway dysphagia. The E is early mobility, getting patients up and out of the bed faster, and the F is family engagement. So you put this all together, what does it look like? The best phrase I can tell you is an awake and walking ICU. This is an ICU where people are awake and walking rather than in a coma, lying in a bed, appearing as though they're dead, except for the monitors that tell us otherwise. So the A2F bundle is a way for nurses, therapists, and the entire team to get people awake and out of the bed with their family there and up and moving, which will also bring them back to a period of eating and communication more quickly.
Yeah, and I think too one of the other points I really wanted to bring up was there a pivotal point for either of you in this movement towards I've read the book, so I know kind of the pivotal point for you, Dr. Ely, but for Dr. Donahue, was there a pivotal point for you in working with this population where you said, okay, I want to look more into ICU care and seeing how we can be involved more consistently earlier on and what our role is in the ICU?
Yeah, I mean, I think some of it stemmed from my postdoc work. So during my postdoc, I worked with Dr. Emily Plowman, and we were doing kind of prehab approaches in folks that were going to undergo a cardiothoracic procedure of some sort. So seeing, are there ways that we can actually help prepare people better for surgery, kind of bolster their physiological functional reserve, improve their frailty, and maybe help with improving postoperative outcomes. And I think while things are a bit different with general ICU folks where we don't always know, ahead of time that someone's going to end up in the ICU, right? And so they end up in the ICU. And like Dr. Ely was talking about, there's all these ways that we can start working with them early on, though. And I think strategies like early mobility make so much sense to me, where we do know, at least in the dysphagia literature, that some of the biggest risk factors for folks are just being generally weak and deconditioned. And that just comes up over and over and over again across a bunch of different patient populations. And I'm sure you've seen this in your work, but for me, if I have an outpatient who comes in, let's say a head and neck cancer patient who they're walking around and they're really active, and you do their video fluoroscopy exam and they're aspirating everything, I'm much more aggressive with someone like that because they're
Yeah.
less likely to develop pneumonia when they're strong and they're very active. And you can, teach them strategies certainly to mitigate aspiration, but I'm much less worried versus someone in the ICU when I maybe see them with a fees and they're aspirating everything and they're so weak and deconditioned, they're not really moving around all that much. They have so many more risk factors and things that are stacked against them. And then, like Dr. Ely was talking about too, with people who have delirium, or maybe they've had a stroke and have cognitive impairments, or like this morning, I saw someone who was very aphasic and had really a hard time just following directions during the feeds. And that made their swallowing problem much more severe and makes me much more likely to be cautious moving forward because they're just not even able to follow commands consistently. So I think all of these things fit into one another, but I do think that a lot of healthcare is shifting to how can we be more proactive? How can we start doing things with people earlier on and to kind of speed along their recovery and their ability to go home sooner too, which everyone wants.
Oh, yeah. And I always say breathing is more important. If you're not breathing, your swallow is probably impaired, and we're not in a place where we should be safely necessarily doing full-blown pizza meals and snacks of pudding and all the things. We have to focus on that upper airway restoration process first.
You asked
Um,
me about my pivotal points, and you said I read the book, but I don't know that you've mentioned the book, so I'm not sure your listeners know what you're talking about.
oh, yeah, it was in your bio, every deep drawn breath.
Oh yeah, okay. Well, I'm going to read you something from this book, Every Deep Drawn Breath. This book is a book of narrative nonfiction, and I kind of make this huge admission to the reader at the beginning in the author's note. And I thought I would just read you a tiny bit of that. I say, early in my career, I strayed, not intentionally, but out of a desire to control every medical circumstance. I didn't listen well enough. Our greatest treasure is found in deep, real communication with each other. And when this is nurtured, especially in times of suffering, two people can establish something of almost mystical quality, a reciprocal connection that brings us into a place of charity and empathy that crosses cultural, social, and racial boundaries. But without such communication, we remain miles apart. And, obviously, a speech and language pathologist is here to help us with communication. So I think this is a really relevant admission on my part as an ICU doctor that I was missing the big picture of what my job was at the bedside. I thought that I was to put in the chest tubes and the central lines, the ET tubes, but really this is about an entire human being that I'm trying to find in the bed, the person in the patient, not the person in the gown, and not the the set of lungs that have gone bad or the heart that's gone bad or the kidney problem. And for us to be truly humanistic and to recognize the mind, the body, and the spirit for the person, we need to be able to communicate with that person, which is your expertise. This is what you help us do. That's why you do cognitive rehabilitation after strokes, and that's why we're doing randomized controls right now of cognitive rehabilitation after the ICU, because we know that our ICU patients leave critical illness with an acquired dementia after having had delirium. And in the prologue of Every Deep Drawn Breath, I call it EDDB, for short, Every Deep Drawn Breath, EDDB. I talk about this patient of mine named Teresa Martin, and she was the first patient I had as a resident who I, without a doubt, know had PICS, post-intensive care syndrome. Even though it was 20 years before PICS was ever named, she came back to us in the hospital, in the clinic after she'd been in the ICU, and she couldn't walk, she couldn't bathe herself, she couldn't go back to work. Her mother was totally confused about what was going on with her, and she just looked at me and said, "My daughter is a very old woman now," and she was in her 20s. So this is where I felt so convicted that I knew that I had done something iatrogenically harmful to her through intense over sedation, over immobilization, and that we had caused her tremendous harm. So that's, to me, what led to the next 25, 30 years of building this ABCDEF bundle. And right now on this podcast right here, I'm issuing a clarion call for the SLPs out there listening that we need you. We need your help. And it's been late in coming that we have built that into what we're doing here at Vanderbilt, thanks to Dr. Cara Donohue. I'm just extremely grateful that she's part of our team now at the CIBS Center, CIBS, Critical Illness, Brain Dysfunction, and Survivorship Center. And it's a joy for both of us to be on with you today, and hopefully have your listeners, maybe find their way to Every Deep Drawn Breath, read about this, listen to this podcast, and realize that they have a role in the ICU in this very, very important public health problem.
Yeah. And I think the role of the caregiver, that's something that I speak a lot on when I'm doing various lectures at state conferences and nationally. The role of the caregiver is so important in incorporating them in that care, because a lot of times, especially in ICU, for me, when I was working in a trauma center, I didn't know the patient prior. Now, there were times in the rural country hospital where they were the frequent flyer, so I saw them every 3 months for their tune-up, and they might come back to ICU and be completely different than they were on discharge on this next admission. And so, but the whole point is that a lot of these patients will come in and we don't know them prior. We don't know their history. We don't, we get their medical history, but we don't know their social history. We don't know their educational background. We don't know what the psychosocial status of was with these patients. And so to have a caregiver, whether that's a friend, a neighbor, a family member, have that to fill in the gap for us is super helpful too. And that's something that you talk about in the book as well, is combining that caregiver role. And I think a lot of us as healthcare providers are doing more and more of that.
Cara, let me ask you a question. What do you feel like now as a caregiver at Vanderbilt on our CIBS team, knowing that we've been doing this work for 25 years and we didn't have an SLP? How do you feel about that and the fact that you're now such an active part of research and now this communication strategy of helping other speech language pathologists and other caregivers and the caregivers at the bedside to be a part of this?
Yeah. Well, first of all, when I got to Vanderbilt, I was surprised that you didn't have a speech language pathologist already that was working with you all. But I think It's been really great getting involved, and I think there's so many other rehab professionals that have been involved with the SIB Center, so I think there's a lot of great opportunities to kind of collaborate across, like, PT, OT, and speech, and like I said, I think a lot of the approaches in terms of things like early mobility or how do we actually rehabilitate all of these things that do happen while folks are in the ICU, I think will really take a multidisciplinary team effort, so I think that there's a lot of exciting work to be done. I was going to say too, you had been asking about pivotal moments, and I was thinking a little bit more about it too. And really, when I was a practicing clinician, the whole reason why I went back to get my PhD was because I was so frustrated with the swallowing treatments that we were doing, and no one could tell me why we were doing them and who they were appropriate to do with. And that was really what led me to go back and get my PhD. And I still, to this day, am sitting around, thinking as a clinician, why are we doing these things? And what are the best treatment options to actually get someone to improve as quickly as possible? Because it is such a big quality of life piece for folks. Related to caregivers, I think that there's a lot of work to be done from a swallowing standpoint too with caregivers. I've been really pleased with some work from colleagues in the field that have been looking more at caregiver burden and that have developed caregiver burden tools related to swallow function. So Dr. Samantha Schoon is one, and then Dr. Ashwini McDonald is another one that have kind of developed these ways that we can actually assess caregiver burden related to swallowing. But there's not much done actually in the critical care setting in terms of actually looking at caregiver burden or looking at it when people discharge home. And I think something I've been learning a lot as a clinician and a researcher is that sometimes I think I have communicated really clearly with patients and families about directions, like these are your exercises, these are like recommendations. This is even if you're recommending a modified diet, how you actually prepare things. But I think there's a lot of gaps in knowledge when we send those things home with folks. And I think it ends up being really stressful and burdensome when people don't really feel like they have the support needed to follow through on recommendations we even provide.
Yeah, and when you've worked in the emergency department, been paged down there, and you get down there, and one of the first questions you ask the family or the patient is, "What were you eating prior to this happening?" "Oh, I was eating everything. I was eating a regular diet," and come to find out they might have had a stroke 5 years ago, and they were not indeed eating a regular diet. But we don't. Again, we have to break that down for people because we're not always using what we consider to be layman's terms, but we're not being specific enough in the questions that we ask. And I think that's an important part to relate back to ICU delirium because sometimes in the ED, that's sort of where it starts, right? They sort of get this medication cocktail and now they've moved into ICU. And not only are they not really safe to start eating right away, but we're not able to get the background information that we necessarily need. I live in a highly military community, so there's a lot of transient folks here that, I might see them at one point and then I may never see them again because they've moved somewhere else. I've had spouses of active duty who had head and neck cancer in their late 30s, early 30s, and that was the case. Like I saw them for a short period of time, so I know that was a little rambly, but I say all that to say there's a connection across the continuum of care where medications play a role. And I can kind of relate that back to last year. I am fairly certain I had COVID for the third time, but my test was negative, but I had the same symptoms I had the first two times I had it. I got really sick. The cough lingered for about 4 weeks, and on Mother's Day weekend last year, I had actually had an intermuscular hematoma that ruptured that I didn't know I had because I was just bracing the cough like a heart patient with a pillow for like 2 weeks. I was like, I'm fine. What do I do? Take an Advil, go to bed. Exactly what we tell our patients not to do. And what's the first thing they do when they admit me directly to the ICU? Drugs. They want me to give me Dilaudid. And I'm like, absolutely not. It hurts, but I don't think it hurts that bad to put me immediately on that cocktail of all the things. I wanted to be present enough to be a part of my care because I was terrified. So it makes a lot of sense once you've had that experience that is more personal because we think we know how to be relational to our patients and develop good rapport, try to be an active listener, but in all actuality, they're not always a partner in their own care. And I think that's sort of the point that I got from reading Every Deep Drawn Breath, that we need to be more inclusive holistically, which is something I think, Dr. Ely, you really drive that point home quite well.
Well, your story is very moving, and I'm really sorry that you had to go through that. It sounds actually terrible. I'm sure the pain was immense. And everybody has to figure out their own pain threshold. So I know you're not encouraging everybody to not get any pain meds because you did what was right for you, but everybody has a different situation. What I'm so encouraged by what you said is that all of us on this call who are listening and speaking can find a place where we get better at caring for people. I just want to keep changing and seeing people for who they are in the bed and not thinking of this as a box to check or a set of tasks to do during the day. And I start this off every time when I'm with my patients by what I call, Wes's 4 questions. And these aren't rigid or anything, but I just ask either the caregivers or the patients one of these or all 4 of these questions, depending on where the conversation takes us. What is your loved ones, or what are your favorite hobbies, your pets' names, your favorite food, and your favorite music? And what I've found is that if I can find out something like that about their favorite music, food, pets' names, or hobbies, then it brings me into this person as a human rather than me seeing them as pneumonia or sepsis or pyelonephritis. And it's amazing how quickly I can then go much, much deeper, even maybe into their spiritual lives, what moves them, what their goals are. And then I try to do what's called switching the preposition. Instead of saying, this is what's the matter with you, I say what matters to you. And if I do that and switch from with to to, what matters to you, then I can quickly start to focus my brain around this person. For example, I had a man who was suffering from severe liver failure not too long ago, and I actually have permission to tell his story, but I won't mention his name or anything, but I've signed permission to share a little bit of this. And he was, extremely jaundiced, anasarca, really, really suffering from all these things, including peritonitis. And I was just thinking liver failure, belly pain, paracentesis, antibiotics. And I said to him, what matters to you, instead of telling him what was the matter with him. And he said, I haven't seen my daughter in 10 years. And so quickly, everything in my head became about him getting back with his daughter. And before too many hours went by, we had his daughter at his bedside, and they had this incredible reunion and reconciled so many things in their relationship. And before he did die later that week, this was the most important thing in his life. And we were able to make that happen at the same time that we were reducing his suffering through palliation. I would not have been there to do that years ago. It sounds silly that I would say that, but years ago, I wouldn't have come to that as early. And I very likely would have missed the window for his cognitive, because he was developing delirium, but she was able to get there before he went into profound delirium encephalopathy. And so that was the key moment. I think many times I've probably missed that precious window.
Yeah, I think that's really important to talk about too, is a lot of times I know in the past for me working in ICU, I'd go in and do a handoff with nursing, and no offense to nursing because I love nurses. I always say they're with the patient so much longer than I am, and they're my frontline hope for giving me back that piece that I need to make a better treatment recommendation or a better recommendation for instrumental assessment for swallowing. But one of the things I would find is that they would cancel the order if the patient was moving towards delirium for an evaluation for speech. And that was just what they had been taught. It was the practice that was going on at the time. This was more than 5 years. It was pre-COVID, but then it kind of got worse during the acute care years of me being in the ICU for COVID. But hats off to everybody that's been in that space, because I don't know about you all, but the mental health of myself definitely changed after working in that environment. But I say all that again to not ramble on, but just to say that I think a lot of it was lack of education or lack of changing the protocol, changing the norm, like you mentioned, changing that status quo of what we've always done in order to better accommodate what the patient needs before it's almost like a too late status or a damage is done and we've got a lot more work now to get them back to some semblance of life versus if we had intervened earlier.
I totally agree.
Yeah, and I had a question that I had written down and thinking about what I wanted to ask. Is there any specific diagnosis like dementia or like a metabolic encephalopathy or hepatic encephalopathy in general that really influences decisions when it comes to sedation in the ICU? Or is it more the protocol has moved towards any general diagnosis where the patient might need some sedation?
It's a great question. I'll say that there are pretty good data to show that when people have cognitive impairment, like pre-existing dementia, or when the doctor and team judge that the patient has a neurological impairment, we are much more likely to withdraw support. And a very famous paper by Deborah Cook in the New England Journal of Medicine years ago showed this. I actually cover this in every deep drawn breath, because when I saw that, what happened in my brain was, wow, if people are over sedated, and their oversedation makes them look like this coma is maybe disease, generated, I will make the judgment in my head that this person isn't survivable, even when perhaps I'm the one who did it. And that scared the crazy out of me, because she didn't even bring up sedation in that paper. But when she told us that, when she showed the data so clearly that we were more apt to withdraw support, I knew that I was guilty and that I had probably done that in my life. So yes, we both interpret a depressed consciousness, a RASS -4, RASS -5. That means you're not responding to verbal stimulation, as potentially long-standing and or bad prognostically, even if we have done it with the drugs. And also, if they do come in with documented dementia, mild cognitive impairment, or stroke or something, we know that worsens the prognosis. What that does to us in terms of our decision-making with regard to sedation is it ought to help us to avoid using longer-acting drugs and psychoactive medications, so that we can have a more clear understanding of where they are within context of brain function. But unfortunately, protocols don't do a good enough job of stopping us, because in the end, it's human decision-making. And if people look anxious, we oftentimes knee-jerk into giving them benzos and propofol for too long.
Yeah. And again, my own experience, it was terrifying to be on that end, and it's something I don't recommend. I highly say, if you can avoid it, don't do it. It was not a fun time. And there are blocks of time that I don't remember, which could be, a little bit of shock and trauma, and also some of the medications. I think there's a component there that is definitely connected, because if you're in shock and trauma, your brain is in survival mode, right? So you're changing your brain chemistry by adding in these chemical components, which makes it a whole much more complex conversation. One of the things that I wanted to get back to, though, with Dr. Donahue was talking about, I know you did mention systematic review, but looking at the frequency of using instrumental exams, kind of advocating for that when it's not necessarily supported. I know in my own career, I really didn't have a ton of physicians who would fight doing an instrumental exam. There were some along the way, but most of the time the physicians have been very supportive, because they knew, like we talked about before, just like with the bleed of some sort, you want to get a CT to see where the source is. So for us, we need to know that physiology behind the impairment of the swallow. So is there any like tips or advice you could give to anybody who's listening to maybe advocate a little bit more?
Yeah, that's a great question. I think I luckily have, for the most part, also had positive experiences actually being able to advocate for instrumentals, whether that's fees or video fluoroscopy with patients. But I do know that's an issue. It's certainly something I've run into before. I think a lot of it, like you said, is providing that education about why we actually need those tools. And I think the more that people realize how important it is in terms of how it also translates to health outcomes. So just knowing that if someone does have a really severe swallowing impairment, that can also lead to other medical complications, and why it's so important to intervene early and to actually, like you said, determine what is the underlying impairment that's actually contributing to someone having something like penetration and aspiration or pharyngeal residue, so that we can actually provide more targeted treatment approaches to improve the swallowing physiology that will then lead to those improvements in the functional swallowing safety and efficiency. So I think a lot of it's education. I know before Dr. Ely got on today, we were talking about my PhD and postdoc mentors a little bit, and my PhD mentor is Jim Coyle, and I know he used to just casually leave research articles like for nurses and like physicians like around the units, like pertinent to like topics that he was like trying to like reinforce. So that's one strategy that I've picked up from him as well. But I think also just having opportunities to dialogue with other healthcare professionals and even just learn like what do they actually know about swallowing, because sometimes they only know about aspiration, but there's also a lot of other ways that we determine dysphagia severity. So I think a lot of it is education of other healthcare providers, because my understanding is that not a lot of other healthcare providers get a lot of knowledge about swallowing assessment or treatment, or how you even screen properly. And so I think that as speech language pathologists, the more that we can kind of partner with other healthcare providers and provide that education, I think we're going to have better outcomes and better responses when we do ask for different types of assessments.
Yeah, one of the things that I started doing, and I know a lot of the SLPs at the same health system started doing, was including the research little citations in our documentation for those that didn't understand the penetration aspiration scale, for example. And, that would change the game, because people who are working in a science-based world want the science, right? They want to know the why. It just doesn't compute if you're just saying, oh, well, this is because we're doing it this way because this is how I was trained. No, you need to back that up with the actual literature that says this is why we do this and this is why we're doing this for this particular patient. And I know that both of you have a little bit of time constraint, so I want to, Dr. Ely, have you jump into talking about the overlap between CIBS and those signs and symptoms that you see with a TBI patient that we're sort of, I think we tend to compartmentalize those pieces, right? So we have this TBI diagnosis, then we have this CIBS, and we think about them in silos. So how do we make that connection, or how did you make that connection, that wow, the wow moment?
Oh, thanks so much. That's a really, I'm so glad we're going to touch on this. So, 25 years ago, when we founded the CIBS Center against CIBS, critical illness, brain dysfunction, survivorship, we did not have trauma in here at all. And now we have trauma surgeons who are part of our CIBS Center. We have about 100 people in the CIBS Center, about 30 or 40 faculty, and then 60 or 70 staff. And now TBI and trauma is a big part of what we're studying with federal grants, and we're part of the National Academy of Medicine's TBI consortium. And what we see is that there's a big overlap between the type of long-term survival problems that people with traumatic brain injury have and the long-term survival problems that ICU survivors have. Myself personally, I have a daughter who has chronic TBI from a fall off of a high diving board years ago when she was little, head first onto the cement. It was a terrible thing to happen in our family's life. I love her to death and she's amazing, but it's caused her long-term, life challenges. And I started crying in the room just a couple of years ago when I was in the National Academy of Medicine, realizing that my daughter had chronic TBI, because I just had never put two and two together on that, even though I was in the room, because I study long-term brain dysfunction after critical illness. And so my passion scientifically is to try and reduce human suffering for people who come in with a neck down problem like pneumonia, sepsis, abdominal catastrophes, et cetera, and then end up with post-intensive care syndrome, of which part of that is acquired dementia. And what I didn't really realize that was in my own personal life, I'd been living with a very similar problem. And so now we do have studies. We have probably about 40 ongoing studies, one of which is the area that now Cara leads, in the area of speech and language pathology and aspiration and dysphagia. And in addition to that, we're studying traumatic brain injury. So we have patients enrolled into our investigations in the medical ICU, the surgical ICU, the cardiovascular ICU, and also the neuro ICU and the trauma ICU. And it's a real privilege to have expanded our resources into those areas as well, to get answers for people for big life problems that we need more understanding of.
Yeah, I agree. TBI was something that I got my CBIS certification for brain injury specialty back in 2012, and I've spent a lot of extra time on not only education, but just learning more about the disorder itself and how it impacts a lot of the things you talk about on the CIBS website. I think that's a really great resource to the research that's being done, not just by you, but by other of your colleagues, because it talks about things like disrupted sleep patterns and all the things that we know. If we've studied more neuro-based cases and TBI cases, we know that it makes sense to have that connection to the CIBS population as well. But I know that again, your time is a little bit limited today. So is there anything that you want to leave us with? Any thoughts or conclusions or last remarks?
Well, first off, you mentioned our website. For the listeners, if you just go to icudelirium.org
Mm-hmm.
or just Google ICU delirium, and you'll see just an array of things there that are meant to help you as a healthcare professional. And there's a medical professional page. There's also a patient and family page, and there's some videos of patients on our endowment page to listen to them first. I think the most important thing I've learned over the years is that my ears need to become larger. I need to be small, and the patient needs to become big. And that's why I kneel down at my patient's bedside, because I'm there to serve this person in the bed. I'm there to serve the patient and their family. And so I need to take my pride and try and minimize it to some degree and gain some semblance of humility, which I'm still working on every day. So send up prayers and thoughts for me about that. But when I do kneel and meet the patient eye to eye at the bedside, rather than towering above them, I can put myself in right place and be there to serve them with this A2F bundle, incorporating the new tools we've got with SLPs like Cara, and to get answers through appropriately designed randomized controlled trials and cohort studies like we're doing right now. It's my privilege to have been here today, and I'm going to get off and let you two finish up. And thanks so much for having us on the podcast.
Yeah, thank you for being here. We appreciate you so much, and thank you for your work.
Appreciate you. Bye-bye. Cara, take it forward.
Sounds good. See you later.
So one of the questions I wanted to circle back when I actually thought about this earlier and then I lost my train because it wasn't one of the ones I wrote down, but thinking about dysphagia and how we know that nutrition overall impacts things like wound healing, cognitive function. And when we talk about research for dysphagia and kind of tying that all in holistically, because again, I think people can, not everyone, but a lot of people still consider like this piece is this and this piece is this, and we're not making that connection across the board. So is there anything that you've done or that you are looking at or maybe have come across as far as how we make that connection holistically about nutrition and dysphagia and our role in that?
Yeah, thanks for that question. That's a really good point. I do think that malnutrition and dysphagia in some cases goes hand in hand, and kind of like we were talking about before with frailty too. I think there's all these different metrics that are starting to be on my radar more, and I think there's certainly more opportunities to partner more closely with dietitians between speech language pathologists and dietitians. I used to do a lot of work at a multidisciplinary ALS clinic, and there I worked so closely with the dietitian that was really great. And I think we're still just trying to figure out what are the best ways for us to partner between speech language pathology and dietitians in the ICU setting and even afterwards too. So I don't think we really talked about this much, but there is this post-ICU recovery clinic here as well. So folks often will come back after they've been discharged from the ICU to this ICU clinic. And I've been in touch with one of the physicians who is the director of this post ICU clinic too, because they currently kind of informally screen for things like continued dysphagia, after individuals have discharged, and also things like malnutrition. But I think it would be great if we could implement more standardized dysphagia and malnutrition screening tools so that we can be identifying folks even after they've discharged from the hospital as well, to make sure that they don't end up getting readmitted or running into other issues and challenges. So that's one thing. We certainly have been trying to implement a lot more standardized screening tools. And I think just in general in the ICU setting too, that could be something that we can be screening for too when folks aren't on the dietitian's list. We can screen for malnutrition. And there are these pretty simple tools that we can actually use. So I think even just building some of that into our workflow to make sure that we're making those proper referrals for individuals too.
Yeah, no, even in outpatient, one of the ones that I used frequently was just the EAT 10 because it's easy, it's quick, it's a
Yeah.
patient reported outcome measure, and it does gain, some insight into how they're feeling and what they feel like their challenges and limitations are. And the other kind of offshoot question for that is, how many times have you seen nursing, or it's usually nursing, but I've seen physicians do it too, give the Yale swallow protocol, the 3-ounce swallow test, and they all do it differently.
Yeah, I mean, I think there's a lot of ways to improve on screening tools. There's also been some work done where individuals have even asked, nurses, for example, or other healthcare providers, what are, overt signs and symptoms of aspiration? And there's like 30 plus things that they list. And some of them are things that you would not expect for someone to say as an overt sign of aspiration. And even in terms of screening tools, like you mentioned, the Yale, that's actually great if a standardized screening tool is even being done in a lot of medical settings, but it's really challenging to get consistency across the board. So, certainly in some units, and again, this is something we're working to improve too in terms of having more standardized screening tools. And it'd also be great if we had more different types of screening tools and ones that are more specific to certain patient populations. So we're trying to work on some of that as well. But I think a lot of times, like you said, one person might have learned it from one person, and so they do their screening this way, and then other training was done, and so other people are doing it this way. Or there might be 10 different sort of similar screenings being done, and you do lose a lot of sensitivity and specificity in terms of how accurate those screening tools can be when they're not done in the manner that they were developed to be used in. Yeah.
Well, I think this was just fascinating, and I really appreciate your time and the fact that you kind of got this sprung on you and you accepted the invitation so quickly. Like it's only been a couple of weeks since we first chatted, so I really appreciate that. I appreciate the work that you're doing and the impact that you're having in this kind of new space from Dr. Ely's standpoint of having a speech language pathologist on the team. So thank you for being there and for continuing your research. And certainly thank you for being here with us. And just like I asked Dr. Ely, any last remarks or conclusions you want to leave with us?
Sure. Yeah. Thank you so much for having us on the podcast. And honestly, it's been so great meeting Dr. Ely and getting to work with all the folks at the SIB Center. They have been so supportive of me and my career. I think just for all of our dysphagia clinicians that are out there, keep track of your own data, on patients. I always tell clinicians that like the way that we get more data is by doing more standardized, video fluoroscopy or fees or, tracking treatment data with your patients. And I think all of that is really important. I talk to our clinicians here about those things all the time too. And the more that we can kind of get those more generalizable data sets in addition to prospective research studies, the better. So I think keep collaborating as well with other healthcare professionals because, like we talked about today, we really need to be partnering with dietitians and other physicians and providing more education. So I think the more that we can kind of reach out to other healthcare providers and work with them, the more that we can improve our patient outcomes too.
Yeah, two of my favorite things that I think I ever did when I covered the LTAC floor was doing wound care rounds. As I'll just be blunt, as gross as it was to see them taking pictures of stuff and the smells and all the things, it really changed my perspective early in my career to realize again that we're not operating in a silo. And then respiratory rounds was the other because that was where that was like a trach 101 class and a vent 101 class. I mean, you're hands on, you're in there with respiratory, watching them do their incredible work. And it was just a really good experience for me to learn from them. So, again, just thank you so much for the work that you're continuing to do. And certainly come back anytime if you have anything new that comes out or anything that you want to discuss. I'd love to have you back.
That would be great. I know swallowing isn't your favorite, but I'm always happy to come
It's
back.
okay. I have a lot of experience with it. It's just not, I just love a good TBI. I know that makes me sound a little sick, but I just love that population so much. So, and that population also has dysphagia a lot of the times. There's a
It's
lot of
true.
tracheostomies in TBI folks. So again, it's not in a vacuum, that's for sure.
All right. Well, thank you so much.
Thank you. So, speech language pathologists play a crucial role in screening for delirium, particularly in the ICU. So sometimes we're called to administer standardized screening tools. And so I kind of wanted to run through some of the options for that. A lot of these are screening tools that are more familiar for nurses, and we can get training on how to use those and what the ratings are and things like that. So I'll kind of talk you through that as well. We can't officially diagnose delirium, but we can be looking out for early signs and symptoms like we talked about earlier in the podcast. We just need to be looking for things like changes in cognitive function, the patient's perception, their physical function, and then also social behavior. So some of the screening tools include the confusion assessment method, which is the CAM, or the CAM ICU, which is the confusion assessment method designed specifically for use in ICU. We can also be trained to administer the nursing delirium scale or NUDESC. And there's a few others out there. There's some really good resources on the critical illness brain dysfunction website that Dr. Ely mentioned earlier in the podcast as well. They're free downloads. There's everything from these assessment tools to delirium protocols, kind of some more training materials that help you get familiar if you're working in this setting and maybe need to have a stronger knowledge base and a stronger skill set to build your confidence as well to be able to assess these patients as part of a multidisciplinary team. So again, for SLPs, we screen and assess cognitive and communication abilities all the time. So that's kind of our strong suit. So it's one of the reasons we're so crucial in the ICU, in addition to, of course, dysphagia and upper airway disorders. But we're the people who, even in those patients, we're looking at things like the patient's concentration. Are they able to focus on tasks? Do they remember us when we come back in? Do they remember what they had? Say they're eating PO, do they remember what they had to eat that morning? Do they remember if family came by? We were looking at changes in speech. Is their speech slow, or is their processing speed increased? Meaning when you ask them a question, is it taking them a long time for them to respond? And also language comprehension. Are they having a lot of difficulty, even if your language or the nurse's language or the physician's language is super simple? Are they having trouble comprehending what you're saying? That's not in congruence with a hearing loss. It's more the comprehension has changed, and those may be some subtle signs that delirium kind of might be brewing in the background. So for us, we need to be documenting those findings. We need to be hopefully involved in ICU rounds where you're able to say, yeah, I noticed this change in this patient, sharing it with the physical therapist, the occupational therapist, the dietitian, all of those, respiratory therapy. I love respiratory therapy. Sharing that with all the kind of key players helps us all to be on the same page and maybe get ahead of delirium and be able to help reverse it or prevent it before it happens. So again, we're working collaboratively with other professionals. Again, we're looking at changes in cognitive function. When I mentioned perception, that would be those times when you go in and the patient's having visual or auditory hallucinations. For those of you who've never experienced it, I see it a lot with people who have withdrawn from alcohol or other substances. They usually see someone in the closet or someone in the bathroom that's hiding, or I've heard spiders on the ceiling. I've heard the water is filling up the room. I mean, there's a lot of different ways that can present, and it just speaks to those changes in the brain that are happening that we need to be speaking up about and mindful of and documenting what you're hearing the patient tell you. Are they now restless? Are they agitated? Are they somnolent, meaning you can't wake them up, or you can wake them up, but they don't stay awake? I used to get a lot from nurses like, oh, good luck with that because this person isn't doing anything this morning. So that lack of cooperation, whether it's, do you want a drink? Or, they're requesting a beer, or they're requesting something really outlandish that they know they don't have access to. Alterations in communication and mood as well. Someone who's quick to be agitated who wasn't before. And then for speech and language, maybe they're rambling, they don't have speech that makes sense. Maybe they're having difficulty with recall of words when you're trying to do an assessment, or just in general conversation. A lot of times we get pushed to do a standardized screening, but sometimes you can also use those informal assessments or those informal observations, and that really gives you a lot of information and feedback. So really the early detection of delirium is really crucial because it helps with, again, the effective management and treatment. and we are part of that picture. So in the last couple of minutes, I just wanted to go through a case study of mine that I had. This was pre-pandemic. This was a lady who was in her early 50s, and it was, I'll give you the backstory. It was kind of a sad, happy, sad story. She had been recently divorced and met someone new. They had kind of done a long distance relationship for a while and decided they were going to do like a weekend away together. So they actually came down here where I live to the beach. And while they were there, she got violently ill and wound up having a GI blockage with a GI bleed. She was super, super, super sick. She had a couple surgeries. She got septic, wound up in the ICU. Pretty healthy-ish before. I think she had had some issues with IBS, but not to this extent. So by the time I saw her the first time, she had been, like I said, 2 surgeries, septic, intubated, extubated, intubated, extubated a couple of times. She was having some respiratory failure. She had lost a ton of muscle, a ton of weight. And so the first time I kind of heard about her, I was actually seeing another patient while they were doing ICU rounds, and physical therapy came up and said, "Hey, we have this lady. I think you need to take a look at her," because they were, of course, looking at getting her cleared by GI so she could hopefully go back to eating and drinking by mouth. But the first time I saw her, she was so confused, and she was definitely in that realm and border of delirium and on a lot of pain meds. Again, surgery was something that, abdominal surgery is incredibly painful. The risk of infection are usually pretty high. So she'd been through all that already. So it was hard to do any kind of assessment the first day with her because she was just so lethargic and really unable to answer questions for the most part. She could do simple things like, "What's your name? Where are you from? Where are you?" She was pretty oriented in that realm, but other than that, just couldn't stay awake. So the next time I went to see her, she was actually in surgery again. And then the third time after she got cleared to do anything for PO trials, I went in with physical therapy and occupational therapist to try to get her to sit on the edge of the bed, or even just to be able to tolerate sitting in an upright position in the bed. Unfortunately, before we were able to do anything as far as imaging goes, she wound up sick, septic again, another surgery. So anyway, fast forward, she was definitely someone who we were screening early on for delirium, and they got in there pretty quickly and were able to help kind of remediate that. She was a little bit more awake and a little bit more alert, but the problem became these multiple surgeries, these multiple instances of sedating medications and pain medications. So that was part of the issue for her. She was in the hospital for a pretty long time. It was kind of an off and on. And if you've worked in ICU, you've seen this before. It's an off and on situation where you go one day, the patient's doing pretty well. The next day you go, maybe they're in surgery, or maybe they've had a change in status overnight, or sometimes over the weekend if you're not covering. And so what wound up happening is it was this on and off kind of battle of trying to get therapy, trying to get anything done, which was not her fault. But what wound up happening is I went on vacation and I came back, and the nurse who had been taking care of her primarily for the whole time wound up leaving. She was moving and resigned and had gone on somewhere else. And the typical physical therapist who covered ICU was not her weekend. And so we all came back hoping that we were going to maybe see her rally and be doing better. And unfortunately, they had discharged her and she went back to Pennsylvania, and none of us ever knew what happened to her. So it's a lot of time and investment that we make in our patients. But again, it's something that you need to be mindful of, and how you are able to kind of assess those pieces and parts and what your patient needs, even if it's these small pieces of information that you can pass on to the physicians, the other team members, and then how we move on from there, even if it's a shorter session, because that's all your patient can tolerate, or if we're able to co-treat with our physical therapy team or our occupational therapy team. So I hope you've learned a lot from this episode. I certainly did, and I certainly hope that you'll check out the critical illness brain dysfunction website. And also, if you get the opportunity, this is not a A disclaimer, I'm not getting paid or anything like that to endorse the book, but I did really learn a lot from Dr. Ely's book, Every Deep Drawn Breath. And so if you're interested in reading that, I would highly recommend it. So again, thanks for being here, and we look forward to seeing you again soon.